Hypertensive disorders in pregnancy are important causes of maternal and perinatal death and disability. It can affect a number of different organs and is then called preeclampsia, severe preeclampsia, or eclampsia. It can occur during pregnancy and delivery and in the days after birth. Definitions: hypertension is persistent high blood pressure, 140 millimeters of mercury systolic or 90 millimeters of mercury diastolic or higher. Preeclampsia is hypertension with protein in the urine or any signs of severe preeclampsia. Severe preeclampsia is characterized by one of the following: severely elevated blood pressure, 160 or higher systolic, or 110 or higher diastolic, or persistent severe headache behind the eyes, or visual disturbances like silver lights or blurry vision, or persistent upper abdominal pain from the liver, or respiratory distress caused by pulmonary edema because of heart failure, or decreased urine production, less than 30 milliliters per hour or 600 milliliters per day. Eclampsia is when a pregnant woman develops generalized seizures. Usually, these women suffer from preeclampsia, though 10 to 20% of women with eclampsia have a normal blood pressure. If fever is present, consider a differential diagnosis like cerebral malaria or meningitis. Causes: preeclampsia is caused by pregnancy and cured by termination of pregnancy. The specific mechanisms for development of preeclampsia are not fully understood. How to diagnose: all pregnant women must have their blood pressure measured at all visits to a health facility. If an elevated blood pressure is identified, it should be confirmed after the woman has been resting in a slightly reclined position. If hypertension is diagnosed, perform a urine dipstick to check for protein and assess signs of severe preeclampsia such as headache, visual disturbances, dizziness, nausea, and upper abdominal pain. Management of hypertension. The management of hypertensive disorders in pregnancy depends on the severity of the condition. Those with mild hypertension and no severe features may go home and come back for a new assessment after 3 to 4 days. They should be warned to seek care if experiencing danger signs, headache, visual disturbances, dizziness, nausea, and upper abdominal pain. Plan delivery at referral facility at a gestational age of 38 to 39 weeks. If the blood pressure is above 150 systolic or 100 diastolic, they should remain at the health facility. Oral treatment could be started if the blood pressure remains in this range. If the blood pressure is above 160 or 110, it must be treated. To keep the systolic blood pressure below 160 is the single most important task to prevent cerebral hemorrhage, which is the cause of half of the deaths due to preeclampsia. Labetalol and methyldopa are recommended drugs. For example, labetalol 100 milligrams given orally can be repeated after 1 hour, or methyldopa, starting dose 250 milligrams orally 3 times daily. You can find relevant drugs, their indications and dosages, in the drug list. If systolic blood pressure is not controlled to below 160, intravenous treatment must be started. At hypertensive crisis, blood pressure above 180 systolic or 120 diastolic, intravenous antihypertensive treatment should be given. For example, hydralazine 5 milligrams intravenously slowly every 20 minutes until blood pressure is reduced to below 160 systolic and between 90 and 110 diastolic. Diastolic blood pressure should ideally not be lowered to below 90 so as not to cause fetal distress. Severe preeclampsia and eclampsia. If a patient has severe preeclampsia or eclampsia, this is what you do. 1. Call for help. 2. Check airway and breathing. 3. Fits are self-limiting. While convulsing, prevent the woman from trauma and tilt her to one side. 4. Insert IV lines. 5. Give magnesium sulfate. As a loading dose, you give 4 grams intravenously slowly over 10 minutes. Never give magnesium sulfate intravenously fast, as this causes cardiac arrest. If no signs of toxicity, give the first maintenance dose. 2 doses of 5 grams intramuscularly, 1 in each buttock. Beware of toxicity. The first sign is loss of tendon reflexes. A more severe sign is respiratory depression with a respiratory rate of 15 per minute or less. Then you don't give the intramuscular dose of magnesium sulfate. At a respiratory rate of 12 per minute or less, or at cardiac arrest, give the antidote calcium gluconate 1 gram intravenously that you must always have available if you administer magnesium sulfate. 6. Manage hypertension. 7. Put in a urine catheter and write down output each hour. 8. Monitor each half hour, respiratory rate, blood pressure, tendon reflexes, and fetal heart rate. 9. Never give IV fluids faster than 1 liter in 12 hours, as it can cause pulmonary edema. Finally, once the patient is stabilized, she must be sent with escort to a referral hospital. As the condition can become life-threatening and will progress, delivery should take place within 12 to 24 hours, regardless of the gestational age. If the gestational age is below 34 weeks, steroids should be given for lung maturity of the fetus, and delivery could be postponed 48 hours for the full effect if the condition is stable.